Good evening and welcome to Doctors on Call. I'm Dr. Ray Christensen from the Department of Family Medicine and Biobehavioral Health at the University of Minnesota Medical School, Duluth campus. And I'm your host for a program tonight on stroke and other neurologic problems. Our guests this evening are Dr. Victoria Heron, a family physician with the Raiter Clinic in Cloquet, Minnesota, Dr. Vikram Jadhav, who is an interventional neurologist with Essentia Health, and Dr. Paul Sanford, an internal medicine specialist with St. Luke's Internal Medicine Associates. Our medical students answering the telephones tonight are Mariah Dahman of Aurora, Minnesota, and Jake Krogstad from Iota, Minnesota. Please call in with your questions on Parkinson's disease, Alzheimer's, strokes, and other neurologic problems you are concerned about. We will do our best to answer them. Our telephone numbers for your questions can be found at the bottom of your screen. And now on to tonight's program. Dr. Heron, I think I'd like to start out, what's the neural system or the neurologic system, and what are the components of it? And then we can kind of work from there as we go through the show.
All right. Starting out, the neurologic system comes in two major parts. There's the central nervous system, which is basically your brain and spinal cord. And then it branches out into the peripheral nervous system, which are the nerves that go out from there into your arms and legs and skin and keeps the rest of your body going.
And all of these affect us differently and help us make decisions.
That is correct.
Very good. I think the other thing that I'd like to talk a little bit about, Dr. Sanford, is stroke. I remember two major types of strokes. Could you talk to us a little bit about stroke?
Sure. Yeah, most strokes are going to be either something called hemorrhagic stroke, where a blood vessel breaks and you bleed into the surrounding tissue, or something called an embolic stroke, where people get a little cork of clot that plugs up a blood vessel, and then all of the brain tissue downstream doesn't have any oxygen.
And Dr. Heron, you and I both practice out in the rural areas. It's always been a struggle in my lifetime as a physician, how to handle strokes. We watched the evolution of cardiovascular and heart disease come a long way over the time that we've been out practicing. But now with stroke, most of our strokes, I think we transfer out of our facilities nowadays, don't we?
A lot of them, yes. The newest, and Dr. Vic can maybe address that, we think of stroke now as kind of a brain attack, that if you can get to the doctor fast enough, because there is definitely a time window that strokes can be addressed, they can actually be treated. And there's all kinds of conditions that have to be met to be treated. They have to be bad enough strokes to be treated. You don't want to cause harm by treating a stroke that maybe isn't very bad, but there's ways that you can treat some of the strokes that used to be just devastating if you get to the doctor in time.
So a setup for you, Dr. Jadhav, as we go into this, because I know that you do the interventional work, and this is really, a lot of this is very new for me too. So can you tell us a little bit about what you do, and then talk to us about interventional things that you can do for stroke and outcomes a little bit?
Sure, I'd love to talk about it. So first of all, thank you for inviting me onto this show. I really appreciate that. And I do agree with Dr. Heron as to the treatment modalities for stroke that have increased in the recent years. So first of all, there are various therapeutic windows for stroke. So you can give a clot-busting medication to stroke patients within the first 4.5 hours from the time of symptom onset, and if the symptom onset is known. Now, with good clinical trials that have come out in the last couple of years, we have actually expanded the repertoire of stroke treatments even up to 24 hours and even later than that if necessary. Now, these treatments may not necessarily be given with the clot-busting medication. Here we have the interventional neurology aspect, wherein it's a specialty that deals with putting a catheter through the blood vessels of the arm or the leg and then going all the way up to the brain to take the clot out. As you had rightly mentioned, there are two types of stroke, the hemorrhagic stroke and the ischemic stroke. The ischemic strokes are the ones wherein a clot is blocking the blood vessel and it is preventing the blood flow to the brain. So in those cases, the catheter-based approach, we can go in and capture the clot and pull it out. In that case, the blood flow is restored to the brain and the patients can have a very, very good outcome. Sometimes if you're lucky and if we capture the symptoms earlier on, we can get the clot out, restore the blood flow to the brain, and the patients can even go out walking to their homes in a few days.
That's really great. And the timing, Paul, is I think back, I remember the 4 hours, and I haven't been in the ER for a few years now, but I remember the 4 hours and the fact that we can go longer. So if I wake up in the middle of the night and I'm not moving so well in the next morning, you still go after this. Is that kind of how you see it with your practice too?
Yeah, when you're uncertain on the duration, you just assume that it was 5 minutes ago, and whether it's something to dissolve clot or an intervention with a catheter to go in and reach and take it out, or even direct something called thrombolytics. Yeah, there's always opportunity. It's a wonderful thing.
So Paul, what are some of the things that get us in trouble in the first place with strokes? Maybe we should be working on the front end instead of, we need to put him out of business.
Oh, there you go. Well, we want to keep people's blood pressures under control, try to avoid eating lots of salty foods, try to have no more cheeseburgers than you have to. And try to exercise every day. Try to have your diet be mostly darker fruits and vegetables. Try to avoid junk food, fast food. Try to avoid sugar. And all my 100-year-olds have only 3 things in common. They had 1 meal a day as a family. They stayed actively interested in something, whether it's stamp collecting or knitting or dancing. And they, would exercise or walk for 30 minutes every day. And it's very interesting. It's the only thing they all have in common.
Victoria, how does the high salt, this is a question that comes in from Duluth, how does high salt intake increase the chance of stroke?
Well, if you look at the risk factors for stroke, running a too high blood pressure is way to the top of risk factors. And some people are more salt sensitive than others, but a high salt diet, and that doesn't just count putting salt on your food. You have to read the labels because unfortunately there's sneaky salt in a lot of foods. So if you have a high sodium diet, your odds on running too high blood pressures go up, and that really does increase your risk of having a stroke.
So do those pickles have a lot of salt in them?
Yes, they do.
Atrial fibrillation, I'm going to stay with, I'm not ignoring you. I'm
No,
going to go back
not
to
at all.
Paul real quick here.
Sure.
So I don't want to talk too much about atrial fib because we did it just a few weeks ago. Right. But what's atrial fib got to do with stroke?
Well, atrial fibrillation is where the upper chambers of the heart just wiggle instead of having a nice, steady contraction. And when you just get wiggling, you get stagnant blood, which will form a clot. And then that clot can fly off like a bullet and plug a blood vessel.
So, very good. I'm going to switch gears a little bit and go into tremors now just a little bit. Dr. Jadhav, what causes tremors?
Tremors?
Yes.
So the tremors, these are just abnormal.
That's a Wisconsin pronunciation, that long E, I think that's where I got that.
Could be just abnormal movements of the arms, and then there could be different reasons. Sometimes tremors could be just because of advanced age, or sometimes they could be just physiological, or they could be pathological, like because of some injury in the brain or something that you have acquired over time. In that case, sometimes you have tremors that are called essential tremors. Okay, so there are various varieties of tremors.
And that essential one, is that the one that causes the head tremors?
Occasionally you can, but they're usually like on the hand.
In the hand?
So you
Okay.
can have that. And surprisingly, some of the tremors, they do respond to a little bit of alcohol. So that's one of the diagnostic features. That does not mean that I'm advocating drinking alcohol, but that's just one of the quirks that I just wanted to mention over here. But
So the one that happens as a person, usually I think of as aging, the one that they get with the head. The question was, what causes head tremors?
there are other things, like sometimes you can have some lot of aortic stenosis also that can have some head bobbing, and that can be an acquired tremor as well. So that's one of the ways you can get tremors too.
Victoria, on these essential tremors, are there treatments that you use in practice?
Some medication can help. You can certainly try. There's a number of different kinds. There's some heart medications that can help. There's some relaxing medications that can help. And some people just learn to live with them because they're not hurting anything other than making life rather bothersome at times.
Parkinson's, where does that come from? It describes a certain type of tremor. Vic, do you want to go down that road a little bit? Talk to us a little bit about Parkinson's.
Sure. Parkinson's, it's actually a type of a tremor in which you have, it's called a pill rolling tremor, because the patients, they tend to have the slow pill rolling movement. And it is also associated with a lot of other features such as bradykinesia. So you might have some slow movement, and sometimes you have a lot of difficulty in initiating a movement, and then the flexibility in the joints might be hampered. So that translates into very often impaired gait as well when the Parkinson's tends on advancing. So these are the different kinds of tremors and the pathologies that you would encounter in Parkinson's disease.
Why does Parkinson's cause exhaustion? It's a question that comes in from Moose Lake, actually.
Well, it's
You're sitting
interesting.
over there with us.
Yeah. Well, it's fascinating. Probably about a third of my patients with Parkinson's disease have a drop in blood pressure when they're standing up compared to lying down. And they'll describe just profound fatigue during the day, and they feel normal when they're lying down, but they feel absolutely pooped out when they're standing. And so I've gone now to checking pressure standing up and lying down, and when that's the case, try to back off on any meds that are potentially lowering blood pressure too much.
So probably the best blood pressure is a standing one.
That's the only one I do in my patients with Parkinson's.
It seems to me I've seen something in the literature that there's been some changes in the thinking of treatment of Parkinson's, but I don't remember what it was. Are there some new ideas and thoughts?
Having to do with levodopa, carbidopa?
And neurotransmitters or any stimulation and any of those type of things?
I know that eventually when all the medications fail, then you can actually go in and put some electrical stimulators inside the brain in the parts where the neurotransmitters are released. And that way you can actually have the dopamine release, which is one of the neurotransmitters that is implicated in these pathways. And you can cause the neurotransmitter release, and then that improves your body motion and takes care of the Parkinsonian symptoms. But there are different schools of thought to it, and some people advocate that you should get to this before the neurotransmitters are completely depleted. So that way you actually have some storage, some form of a release mechanism over there.
Thank you. Victoria, how does your body take care of clots to prevent strokes?
Well, you're supposed to have a intrinsic, you come with it, way to break down clots. You're supposed to make clots when you cut yourself. That's how you stop bleeding. So you have the thing in your blood that makes the clots, and then there's the opposite of that, that when you're done with the clot, there's proteins that break the clot down. But that's normally when you cut yourself, how that works. If you have part of your heart that's not beating properly, there's that blood just sitting there, and blood just sitting there clots. And there's not enough breakdown clot stuff in your blood to keep up with the clot formation when you have blood just sitting somewhere. That's why, say you take a really long plane trip or you get your leg stuck in a cast, you're more prone to getting a clot in your leg. And that's another thing that can break off and go and cause problems in your lungs, or if you have bad heart, it can go to your brain.
So we've been talking about atrial fibrillation, and you're talking about the heart again. Can PVCs, there's associated wisdom here, do PVCs themselves cause blood clots? It's always been atrial fibrillation is the only thing that I'm aware of.
Yeah, premature ventricular contractions where you have an extra beat in the main chamber is not associated with stroke or clots.
So next question that comes up from International Falls, what is chronic small vessel disease and how do you treat that?
Well,
And I'll just let anybody that wants to bite on that one jump in.
So sometimes there are various stroke risk factors like high blood pressure, bad cholesterol, diabetes. So not all strokes are same. You do not have to have a clot inside a blood vessel to block the blood flow to the part of the brain. Sometimes you can have very small blood vessels, which are basically smaller than the diameter of your hair, multiple magnitudes. And over time, these small blood vessels, they just give up because of the bad risk factors that haven't been managed, especially if somebody has very high blood pressure over a long
Eating
period of
cheeseburgers.
time. and scarfing down cheeseburgers. I totally agree. Once in a while is okay. So because of these uncontrolled risk factors, especially like high blood pressure, these can cause the small blood vessels to give up. And this is what we see sometimes on our CT scans and MRIs, that you see something that is an indicator of a stroke going to happen down the road, because they have a lot of small vessel disease. This is picked up on the CT scan and the MRIs.
So let's take that out to the family and the community, because the question comes in, what are the signs for a risk of stroke that can be seen in everyday life?
That's a very good question. And previously, we used to have an acronym called FAST. And I'm going to expand on that
Please.
acronym. But now that acronym has been expanded to BFAST, because there are some additional stroke features that everybody in the community should be aware of. So B stands for balance. E stands for eye, so double vision, loss of vision. Okay, so that B initially is for balance. So if you have a lot of unsteadiness and you're going all over the place as if you're drunk, but without a drop of alcohol in your body. E is for eyes, loss of vision or double vision. F is if you have a facial droop on one side of your face. A is for weakness on one side of the arm or the leg. And then S is slurred speech. And T is for time. As soon as you get any of these features, your loved ones or your neighbors, anyone notices this, call 911 or go to the nearest ER. Because you want to go to the ER, be within the therapeutic window to get to the clot busting medication. If you're not eligible for clot busting medication, you can still get the catheter-based treatment, get your stroke treatment, and get onto the path of recovery.
Thank you very much. That's very well done. So now the next question that I have, is there anything that any of you can do for a bleed? So we have strokes, like 90% are clots, but that other 10% are vessel pops or an aneurysm or whatever. So we have a bleed. What do we do then? And is there anything interventionally that you can do with that?
No, of course, yeah, as you mentioned, aneurysms. So aneurysms are just abnormal outpouchings in the blood vessels, and they tend to kind of have the similar risk factors, but the two most important risk factors that are modifiable, that are in our control, are high blood pressure and smoking. So if we take care of these factors, then the aneurysm risk can be lowered. But then there are some risk factors that you cannot put me out of business for, because they are genetically acquired and we just cannot help it. So because of those also we can have aneurysms. So if an aneurysm ruptures, it's very devastating, because for example, there are not a lot of aneurysm ruptures, say about 30,000 aneurysm ruptures in all of US. That's a low number. But when an aneurysm ruptures, 25% of those people never make it to the hospital. They die before coming to the hospital. Even if you make it to the hospital, 15 to 20% will still end up dying. And if you have an aneurysm rupture, 2/3 of those patients will have a permanent neurological deficit throughout their life. So it's a very devastating stroke, not only for you, but for your family as well as for the community. How do we take care of those aneurysms? We can use the same catheter-based treatment, and we access the aneurysm through the blood vessels going all the way up to the brain, and we put coils in to seal up that part of the aneurysm from inside. So once that outpouching has been sealed by putting coils in, that part is taken away from the circulation, and then the blood just flows through the blood vessel. And you can have, there are a lot of recent advances wherein you can put in stents, you can put in some balloon-assisted coils, and a lot of newer devices that are coming up. Just to give you an example, about 20 years ago, most of the aneurysms used to be clipped by opening up the skull and putting it actually clipped. But now, almost 90% of the aneurysms can be taken care of by just a catheter-based approach with a minimally invasive approach, and that leads to faster recovery for our patients.
So I heard this word blood pressure. Two primary care docs. What's normal blood pressure? Where should we be with our blood pressure with our elders and so on? And you've already told me you don't want us standing up and falling down.
Right, you don't want too low.
But where do we go? And what's the right number?
There are several different bodies, from the American Cardiology Society. It'd be nice if they could make up their mind. Unfortunately, we have several different guidelines. They're evidence-based, they're based on studies. They keep coming up with new studies which gives us different targets. One of the most recent studies out reinforces the fact that lower actually is better. As long as you're not fainting, getting it down to 120/80, no matter how old you are, is more where you want it, as opposed to A little bit ago, they were saying, okay, if you're older, maybe you can let it run a little bit higher. Well, you can, but then that does increase your risk of having a stroke. So getting it down, even if your birthdays go up, you still want your blood pressure down.
Good point. Is Parkinson's disease genetic?
Wow, it's a very good question. I think there are so many different variations of Parkinson's disease that there may be some paraprotein associated. What's the word?
There is actually, there are some of them which are genetic. In fact, one of the famous cases, and this is public knowledge, so I can speak about it on TV. One of the founders of Google, his mother actually has that genetic component of genetic Parkinson's disease. So they have actually invested some money about for this research as well. And I'm not plugging in for Google, I just happen to know about it.
That's right.
It's called the LRRK gene.
Who is, slipping back and forth in the same discussion here a little bit, who is not eligible for clot-busting drugs?
Oh.
So you started this discussion.
Okay.
One of you kind of said it.
One of the points if you come in with, say, a definite stroke, but it is very minor, say you just have a little weakness in one hand, it's still working, might even be your non-dominant hand. Anytime you give clot-busting medication, you are running the risk of, say, turning a non-bleeding stroke into a bleeding stroke. It's in the list of things that could possibly go wrong. So you do have to take a good look at, okay, what is the problem? What's the deficit? Now, you can monitor something and see, is this something that's progressing? You think it's going to get worse? Okay, in the time frame, probably go ahead and give it. Or it's actually getting better. And you may not want to risk turning it into something worse if you have a very minor deficit to begin with. It's a judgment call.
So that brings in TIA.
Right, transient ischemic attack. It's sort of a gift from the heavens, a warning sign where all of a sudden my face is kind of slurred and my face is weak, voice is slurred, a little bit of weakness in one hand, and then within a few minutes it completely resolves. It is a divine warning sign saying that you got to reduce your risk factors. You got to have some imaging done to make sure you don't have any narrowing in major arteries. You got to start some type of a medicine to make your blood more slippery. And you need to see somebody like Dr. Vic here. So
then the next question, this person really winds this in a little bit differently. Is it common to have extreme sensitivity to light / migraine symptoms after a TIA? Or now we're really getting into the tough stuff. Or are they related somehow?
Could be, because it depends on which part of the brain has been affected. So sometimes if the part of the brain that is responsible for interpreting your vision, right in the back over here, if that's affected, you can have some visual auras also, and you can have some visual symptoms. Sometimes you can have a part of the brain called cerebellum, as it links to the other parts of the brain, to the cerebellar peduncle. You can actually have visual hallucinations as well. You might actually see some things. So these are also signs of, very rare though, signs of TIA/stroke. Although TIA is a transient ischemic attack, we tend to clump it together with stroke, and we treat it the same way as one would approach stroke too.
Please go see your physicians.
Go see your physicians, and at the same
primary
time,
care docs. And
charity begins at home. Make sure you start taking care of things at home, as everybody has discussed.
Yeah, quit smoking, quit eating your cheeseburgers.
Yep.
Except I love cheeseburgers.
What percent of salt, what's your salt guideline?
Well, I can't measure how many grams a day I get. You're supposed to have no more than 3
Well,
grams of sodium.
they ask you to.
Yeah.
What's the matter with you?
I figure just look at the cans and, things like tomato juice cans, soups, pickles, lutefisk. These things all have a lot of sodium. And in fact, even in like canned fruits, it has sodium phosphate to maintain the color. If you can without some type of sodium, everything turns gray.
Victoria, does he need correcting? Is he okay?
Yeah, the American diet just has a lot of sodium in it. If you eat fresh or frozen, if you avoid things in cans and boxes, you're way better off.
Amen.
Yep, fresh stuff.
We're quick running out of time,
Oh.
and I think I'm going to kind of just bring us to an end because the other questions, there's a couple that we didn't get to. I first of all want to thank everybody for watching tonight and wish everyone from all of us a very happy holiday season. I want to thank our panelists, Dr. Victoria Heron, Dr. Vikram Jadhav, Dr. Paul Sanford, and our medical student phone volunteers, Mariah Dahman, Jake Krogstad. And please join Dr. Paula Termula in 2 weeks on January 3rd for a program on cancer, surveillance, and prevention, when our panelists will be Dr. Brett Friday, Dr. Adi Lakari, and Dr. Sandy Stover. Thank you for watching. Good night. Have a great holiday.